It's wonderful to be here with you all. We have, I think, a really extraordinary group of people up here today. I was in a session earlier this morning with Judy Woodruff and Atul Gawande, and Judy Woodruff said something very simple and very useful, talking about people who are inside the circle of healthcare. I think she was talking about providing healthcare, et cetera, and people who are outside of the circle. And as somebody that has obviously been on the outside of that, not in any way providing healthcare, I certainly think of myself as an interested user of healthcare, but also the technology that is driving the delivery, the service delivery, and the user experience of how we interface with our healthcare system, as well as with our healthcare providers. And so I've been thinking about that a lot, but I also know a bunch of medical professionals, including my parents who both work in healthcare, and they think of themselves not just inside, but also outside, as patients, as users themselves. And so I feel relatively qualified to talk about myself as a user. I feel completely unqualified to be moderating this panel on the digital revolution. Thankfully, I get to ask dumb questions of these smart people to hopefully share some of their wisdom with you. Just to give you a bit more background, I'm an architect by training. I work primarily in philanthropy and strategy consulting these days. I work for TED. It's a philanthropic program called the Audacious Project, and I mention that because several of the early investments that we've made, very large-scale investments in the tens of millions of dollars, have been to organizations in this space. And so I've had a chance to learn about their work and about their needs. I also do a lot of work with the Aspen Global Innovators Group, as well as the Aspen New Voices Fellowship Program. And I'm so delighted to be back here with you on this stage today. One thing I'll finish by saying is that when I acknowledge to our panelists that this is not my usual area of expertise, most of them very kindly responded and said, "Welcome to this conversation. Thank you for moderating it." But the first speaker that I'll introduce, Bill Evans, provided a very helpful roadmap about some of the issues that are interesting him, concerning him, and in a few cases, challenging him. And I thought I would start with Bill on the far side of the stage here. And as I'll do with Bill, I'll introduce every person as we give them a moment to make some opening remarks about the kind of work that they do and why they feel it's so important. And then there'll be some exchange between the panelists, and then we'll open it up to the audience for some actual Q&A. I find that in a lot of these panels, the Q&A time with the audience gets very cramped, and I hope that we have ample time for that as part of this deep dive. So Bill, you are the managing director of Rock Health, the first venture fund dedicated to digital health. That's a pretty significant thing. One of the things I loved about your website, beyond your portfolio of folks that you work with, are these little fun facts, very personalized facts about each one of the people in your firm. And something to know about Bill that is actually very important, I can tell you as a parent, is that he attends an average of 1.2 birthday parties per weekend. So he has 4 kids, and as I mentioned, when I expressed some intimidation about this group, he provided this helpful roadmap. And he asked a question that I'm sure he intended me to ask of the other panelists, but I thought I would just turn it right back toward him and ask you this question. And it starts with a little bit of preface that you had laid out. So we live in an era where trust in technology firms and those who track our data is plummeting. What does this do to digital health, and what can digital health do about it?
Yeah, wow. So we're going right to the heart of the matter. Well, first, thank you very much for having me on the panel. So this is really important to the entire health enterprise and to digital health. It's important to Rock Health. We invest in early stage companies and we support them through their very earliest stages of development. And so this issue for us manifests in a few ways. We're located in San Francisco and Silicon Valley, and we live in an environment where tech is axiomatically good, and what tech does and leads with is good for America. Except that we're seeing a counter-narrative emerge really strongly around Facebook, around some other companies in the industry that are not handling data in the way consumers implicitly or in some cases explicitly expect it, right? And so that's creating an environment of distrust, congressional hearings, and a backlash.
Mm-hmm.
And so my sort of reasoning around this is simple, that digital, to a person, to a consumer, digital health is not distinct from, in tech, health tech is not distinct from tech.
Mm-hmm.
They're all of a piece. And so there's an impact to, a negative impact to anything we want to do in healthcare around technology, insofar as we fail to account for the secular trend.
Mm-hmm.
Right? And so then there's, I think, some implications that this panel is really well positioned to discuss. The other side of that, which you asked, is sort of what can digital health do about it? And I'll just state my affirmative view, because the problem, it's easy to be an expert on the problem, right? But I think the other side of this is that we've got to teach the rest of the world that there's 2 A's in HIPAA, and that privacy regulation isn't something that pulls down as an anchor on innovation, a slowing force in innovation. And there are renowned investors in Silicon Valley who I respectfully disagree with in the viewpoint that HIPAA, for example, is a drag. What I think it actually is, and the rest of the sort of approach that we can take and brand ourselves around, is a stamp of approval and a branding exercise that establishes a high level of trust. Now that creates more burden for us as innovators, and there's some things we have to account for in doing that. But my argument is fairly straightforward, that that's actually brand value in an environment where everybody else is going the other direction.
Okay. Thank you, Bill. That was super helpful. I promised myself that I would ask questions that I thought other people in the audience might have. Can you just explain a little bit of what HIPAA is? I know a bit about it, but we have people from a global audience here, and we have mostly uninformed people like me as well. So just give us a sense of how those two things like literally intersect.
Sure. HIPAA stands for the Health Information Portability and Accountability Act, which is meaningless in this context. But it has several provisions around data privacy that stipulate that anyone who delivers healthcare or supports an entity that delivers healthcare, so a hospital or their business associate, an insurance company that transacts and processes the claims, or anybody who works with that hospital and has access to the information of that entity, has to treat the data in a certain way. And that, to be really cavalier about it, that certain way is a way that, for the most part, you and I would feel is pretty secure and pretty respectful of my needs as an individual, right, as a consumer. They can't just throw my data around in an insecure manner.
Got it. Thank you. Thank you, Bill.
On the panel that I... Okay.
Well done, well done. So Sumi, you know a thing or two about throwing data around. I'm joking, of course.
Yeah.
Sumi is an expert in privacy and security, and she has a long list of affiliations to demonstrate that, having been an academic or a researcher at UC Berkeley and UCSF, University of California, San Francisco, as well as doing some critically important work with the State Department here in the US, as well as the Department of Defense. And she's now with Vulcan, which is one of the many organizations that Paul Allen is backing. And so in your role now as the Director of Technology Advancement and Biotechnology for Vulcan, can you give us a sense of really what is at stake here?
Yeah.
From a privacy standpoint specifically?
From a privacy standpoint, so I will, full disclaimer, our big efforts in digital health are actually in developing countries. And part of the reason is that we feel that we can develop novel solutions more easily with global health partners than we can necessarily in the US. I mean, I completely admire Atul Gawande. We can't touch that, right? So I think, but from a privacy issue, I think there's privacy, security, And then on the other hand, there's openness and availability of data. And we have to find a way as a society to weigh those two, because the downside of not leveraging that data is that we're not going to be as smart as we can be, and we're not going to make the decisions that we can make as a society and learn the things that we can learn by integrating data. So, and when I say integrating data, I mean integrating data from genomics all the way through, what happens with drug interactions. There is so much that we can learn from that.
Excellent.
So.
Thank you so much, Sumi. Your work that you're doing in developing countries is a perfect segue into the work of Josh Nesbit. At least in the worlds that I operate in, when we think about the digital revolution in health, Medic Mobile is one of the absolute first things that comes to mind. Josh and I are about the same age, so maybe it's just a kind of peer thing, but everyone seems to go through Josh Nesbit somehow, so we're very, very delighted to have him here, smack dab in the middle of the panel as well. So he's the co-founder and CEO of this groundbreaking nonprofit technology company, and it's specifically founded to advance global health equity. I feel like your reach is impressive and extraordinary, but rather than a question, I would just love to have you share with the audience where your work originated, what you've achieved in terms of that reach, as well as what you see on the horizon.
Thanks, John. It is an honor to be here with this panel. I'm really grateful to everybody here who's showing up for this session. I'm also really grateful to you, John, for shining a light on dignified design. And everyone should read John's book. It's brilliant. As a writer, I think you would probably agree with me that I think language is really important in these discussions. And I'll just offer up how these conversations might go a bit differently if, instead of talking about digital health, I think the code's going to be just fine. So maybe if we recenter the conversation to talk about human health, animal health, and community health, I kind of wonder how the conversation changes. And if we look at the title of this session, even Digital Revolution in Health, I kind of wonder how the conversation changes if we think about the digital tools explicitly as servants of the revolutions that are happening. And I'll just give one example. We started our work in Malawi. I thought I was going to be a doctor, and I was doing qualitative research on pediatric AIDS, listening to mothers about why children weren't getting access to and staying on treatment. And there was one doctor at a hospital there serving 250,000 people, and patients were walking 100 miles to get to that doctor. It was very clear that system needed to be redesigned. Every single person knew it, including the doctor. And step one was to rethink who we saw as and treated as health workers. And again, the answer was really obvious. There were community health volunteers who were walking 35 miles every week to knock on the nurse's door and demand that they look at how their patients were doing back in their village. And then were walking back home to continue caring for their neighbors. So step one was to think of those community health volunteers as part of the system. Step two was to equip them with the tools we had available using the infrastructure that we had. And step three was to then rethink where the care was being delivered and when. And we started with 200 community health workers, used cell phones to connect them to the hospital. Fast forward 7 years or so, we now work with an amazing group of partners, many of whom are in this room, and support 20,000 community health workers. We're going door to door, providing care for roughly the same number of people as Kaiser supports in the US. And about 1 million home visits and care visits are provided every month by that cadre. So I don't know. I hope that we can learn from those health workers.
Sure.
And
That's great. Thank you so much, Josh. And I, to the organizations I'm most familiar with from a community health worker standpoint are Last Mile Health, led by Raj Panjabi, who's either in this tent or nearby, and Living Goods, led by Chuck Slaughter and a great team of folks. And they both talk about your technology changing the way that they think about their delivery of their mission, as well as the experience both of the health workers themselves and the people who are benefiting from that. But what we're talking about here is basically it's an app on a phone still. Is that correct? And can you just give folks a quick sense of like what that is? It's more than just internet enabled, where you're getting responses to things. It's a diagnostic tool, I assume.
The vast majority of the time, we don't have the internet. Everything needs to work in a distributed way. And because you essentially need to start with the way you want the health system to function and the people who are going to be involved in delivering care, you end up making all sorts of different technology decisions. And I'm really curious to hear about the technology decisions we're going to be making, because I think actually the stakes get higher and higher as the technology improves.
Okay.
So we can talk more about that.
Great. And then has your technology been adopted here in the U.S. at all, or is it all international at this point?
Not yet, all international.
Okay, great. We're going to come back and talk about regulation and its relationship to innovation. But the next two people that I saved for last, because they had a chance to be up on the stage during the opening session, and I certainly was pretty blown away by the things you had to say. They are two people that are, I think, looking at the horizon and potentially beyond that. Jay is the founder and chair of the Human Diagnosis Project, a worldwide effort created with and led by the global medical community to build an open intelligence system that maps steps to help any patient. And you may have heard them make this case in the opening session, but he asked this question: when you or someone you love isn't well, what should be done? And he's basically, I think, talking about kind of pulling out all the stops and working together and really having what you've called super intelligence, which is actually not a term I've heard as much as like artificial intelligence and that kind of thing. But I would just love to hear you describe, kind of how you came to advocate for this approach.
Sure. So the name, the Human Diagnosis Project, you may see has a careful analogy to the Human Genome Project. And when you think about how we make healthcare decisions, it requires every layer of information, not just the genetic code, not just symptoms, not just lab tests. We actually need to create an entire stack of all of the layers of information which actually ultimately impact human health. So that's all the way down to how your mitochondria process electrons at a subatomic quantum level, all the way to what type of society you were raised in as a child. And that entire stack is ultimately what we think of as an open intelligence system that can ultimately help anyone, anywhere. And the analogy that will probably be familiar to most of you is the analogy of the online map. So the online map is something we all take for granted every day. But the first version of that was literally cartography, and then there were atlases, and then there was MapQuest. So you had directions you could print out. But now we have the opportunity to take every layer of data and marry that into a singular system. We have traffic data, weather data, accident data, events data. All of those allow us to optimally plan the route from our origin to our destination. And when we think about what is the origin and destination in healthcare, it's having a problem to ultimately getting and then staying well. And if we want to build that system for society, we have to start now and recognize that it's going to take decades, if not centuries, if not millennia, to build such a system. But we need to have such a system to ensure that everyone on this planet has access to the highest quality care from the day they're born.
And is this the kind of thing you find everyone agreeing with generally, or are there folks that, in the larger discussion about AI, are also resistant to this in some way?
Well, so yeah, I should clarify that our approach is a collective human intelligence approach combined with AI.
I see.
So when an answer is received through the system HumanDX, the system answer is not a pure AI-based answer. It's actually based on the input of physicians from around the country and the world to actually marry the insight that different stakeholders have together into a singular answer. So AI is not just providing information back to the participant in terms of what prior cases or prior information in the system says might be the best approach. It's also being used to synthesize the thought processes of multiple actual humans who are looking at that individual case.
Okay, interesting. And one last question related to this. What is the extent of that network that provides that human input?
Yeah, well, today it's currently at 10,000 healthcare professionals from about 80 countries who are contributing to building this open system.
Interesting.
Now, I should clarify that even today, that is already a reasonably interesting scale. So the largest open source software project by comparison, Linux, has had about 14,000 software engineers contribute to its development. And there's actually about the same number of software engineers and physicians in the world today. So our goal is ultimately to have this impact every single physician, and in doing so, every single patient in the world. But that is kind of the next phase. You can actually get to very interesting scale solely by having a small group of highly dedicated participants caring about what's being built. As a simple analogy, by 2007, when Wikipedia was already the 6th most viewed website online, less than 1,000 contributors had contributed about 60% of the articles to the encyclopedia. So it shows that very small groups of highly motivated and well-intentioned people can accomplish some pretty incredible things.
Great. Thank you so much, Jay. And certainly last but not least, Shada is another person you might have heard in the opening session. She is a visiting scholar at the MIT Media Lab, assistant professor of information systems security at the College of Computer and Information Science at the King Saud University. And so you are an expert in privacy and security issues across multiple sectors related to health. Blockchain is something that you discussed from the main stage. I, once again, don't understand a great deal about that. Can you talk about the implications of blockchain or the opportunities relative to blockchain in the context of health?
Okay. Thank you very much for the nice introduction, and it's a pleasure to be here and talk to you all. It's my first time to Aspen, and definitely not the last.
She said there's a little more sun than in Cambridge, where she currently is. So she's already got some tan going on. So.
Okay, I come from a desert, so I'm already used to the sun, but I miss the sun now. Okay, so going back to the topic, there are two things that we're working on at the Media Lab, artificial intelligence and blockchain. Why both of them together? Now, when we talk about artificial intelligence, and I'll end with the blockchain, we're talking, I know the skeleton here, or the backbone, or the glue here between everything is actually information. So we know that this is essential to make anything intelligent, anything digital, anything intelligent. But what we're trying to do at the Media Lab with Professor Sandy Pentland, the Human Dynamics Group, is that we want to build wise systems. So it's a layered intelligence that builds a wise system where we can actually go beyond intelligence. And to what extent, it is something in progress, but we're trying to reach that level of intelligence that is even, reaching wise, having wise systems. Intelligence is very important to predict, to prevent, to help healthcare in the early stages, and the even prediction to prevent things in the future. So at all stages of it helps, but you need data to do that. Now, in order to share data, in order to use data, you need to access data, and data is really extremely valuable. No one gets to share data easily. So we know that in some cases, like in the opening, I talked about the incident where it was because of the lack of information, many people, including family members, died because they didn't know, the ambulance did not know which hospital to take my grandmother to. It's a simple problem, but yet complex, because the lack of information can cause that, and the lack of information can lead us behind intelligence. So we're talking about essentials and more than that. What we're trying to do is to balance between giving access, but yet not giving people the chance to access the whole data. So we're creating this smart, open algorithm, Opal, which gives or creates a privacy-preserving solution that can help people share the answers. So keep the data in your place, just give me some answers. Some simple answers that can help me decide which hospital to go to, that can help me predict the risks of stroke, from stroke. They can help me make decisions. I don't need your data. I just need some simple answers that can help me make informed decisions that are essential to save lives. Where does the blockchain come in? Well, if you give people the chance to take your data, you need to monitor and audit it somehow. So you need a mechanism that can track where that is going. You want to trust them, but still, we don't know each other. So the blockchain come here to add this trust a component that it builds a trustless system where we don't need to trust each other, but let's trust the technology to help me know where my information is going, what questions you're asking me, and the answers I'm providing you, and who are you, okay? So this is where we use the blockchain in that context, building blockchain that can monitor the access to information to build wise systems. And we're using in different contexts in the healthcare, including urgent care, to make decisions to help the Ministry of Health in Saudi Arabia decide where to take patients to and where to build the most intensive stroke centers next, and how to invest and optimize the system. The other use case that we're using is in clinical interventions, where the interface is actually a robot, where the robot gets to ask the OPAL questions about the autistic child. For example, the child, we have these therapies where the robot is easier to communicate and to conduct therapy sessions with the children, autistic children. So what we do is that we provide the best therapy strategy that is based and tailored around the needs of that specific child by asking OPAL questions coming from the school, hospital, home, to decide and to tailor the treatment session towards the child. So questions would be like, what about this strategy? What are the percentage of success in using this strategy with those specific inputs? And the answer comes 20%, then the robot decides to move on to the next strategy, and so on, making informed decisions. The third last use case is we use it in clinical trials. We're trying to bring clinical trials results coming from different pharmaceutical companies, and we try to help the public and the individual and average user to ask specific questions like, their risk for a stroke or any specific diseases, having this ethnicity and that age and range and so on. And just retrieve answers that can help them make decisions. Could be insurance companies using that. So these are when we allow for answers to be shared to help people get a better quality of life. Blockchain, we work on another project that is purely about blockchain. We call it Healthy Blockchain, where we designed a specific framework, blockchain, fine-grained, patient-centered blockchain that can help connect individual autonomous systems that are not connected, that are legacy. Some of them are legacy. So we know in healthcare today we have different systems. Every single day we buy, healthcare providers need to buy a new system, to get the processing and the healthcare delivery going on. But again, every single system is different. So how can you connect them with each other? It's very difficult. And interoperability between systems has been a problem for a very, very long time. So what we're trying to do is to build this blockchain that can help get the information flowing with the patient. So the patient gets the treatment between different healthcare providers and treatment points. Let's get the information and the full picture painted about where the patient is going, what has happened to him, and what decisions have been made. This is to help the healthcare team member, the care team member, to make informed decisions about this particular patient by knowing more about that patient. And this granularity gets the information about where this information been recorded, which hospital, which information system, which treatment point by which care team, and which treatment plan exactly. This is to help exactly know where the patient has been and the status and everything. Just last thing. When we talk about the blockchain, it helps with the timeline because it helps know which started first and which ended. So it helps to get to know the different comorbidities if the patient is suffering from multiple diseases, so they can get to know exactly what's happening, and no decision would interact with another without knowing this whole thing. And this is the thing that we're working on blockchain in the healthcare system, because symptoms and history, knowing the history is sometimes as important as knowing the symptom, because, a heartburn would tell that it's actually a heart attack just by knowing the history. So not only sharing information in the future or in the current, we need the past, and the past is extremely important.
Okay. Well, that's fascinating, first of all. Secondly, it's clear that there's real implications of this across all of the work that these that these other panelists are doing. I want to understand from Opal specifically who provides the oversight or operations of that system.
We work with the data owners themselves to help them build it and train them to be able to allow others to use to access their data, access answers to their data.
I see.
So we work with the data owners themselves to make it work with them, and they provide the information that they want, the answers that they want. There are 6 principles to Opal to make it work very nicely. First is to keep the data encrypted at all time, and you keep the data where it is, where it belongs. Second, you let the data owners, it can work with one individual owner, but it works nicely with multiple people, multiple owners with the same agenda, like example, multiple centers, and we let a specific user, for example, the Minister of Health, to ask questions coming from all of those centers. And I'll give you an example. Could be, for example, how long does it take patients with stroke and this range, age range, going to receiving treatment or going to centers. And these answers will be coming from all of those centers without pointing to a specific center that it's doing, is not managing the system correctly, or there is a problem with emergency medical services. Not to point to a specific person, but let's get information, valuable information that is accurate to make those optimization decisions. The third principle is to get the execution of those algorithms, queries, and questions executed on distributed repositories, on data sets or data originated in different sites with data owners, in order to receive safe answers. And the safe answers are the more important thing in this whole story, and it's stamped, digitally signed, so you know exactly where it comes. You can trust it to make the decision.
Okay. I think you only got through a few of the points of the 6 points, but
We've gone.
That's fine. That's fine. But you raise this issue of trust, which is one of the first things that we talked about, and so I want to kind of pitch it back to Sumi and or Bill and talk about this. I was trying to understand who the data owners are, if those are individual patients like most of us, or if these are the same these same data aggregators, these technology companies that we're already distrustful of, and just wondering about the implications of that. But I would love your read of this, Sumi or Bill, in particular, the way that Jay and Shada have talked about this.
I can give an example from Global
Sure.
Health. So what we're doing at Vulcan is we're trying to use technology of tomorrow to solve today's biggest problems. We're applying artificial intelligence, machine learning, different types of technologies to solve diverse issues from biodiversity, climate change. Paul has a lot of big ideas. So our job is to try to bring the technology in to either solve for illegal fishing, solve for elephant poaching. And in my case, what I'm working on is trying to solve for pandemics. So in 2013, Paul gave $100 million to help with the Ebola response. Fortunately, we got through the West Africa Ebola crisis. And after that, Paul said, well, what can we do to prevent this? So what we're trying to work on now is really how do we develop a virtuous data cycle that will enable healthcare providers on the front lines, healthcare providers in urban areas, healthcare providers throughout the system to be able to input data but get information back. Because a lot of what's happening with digital health right now is that there's a one-way flow of data. And so, what we really are trying to get to is a broader system that will allow the stakeholders to really benefit from that data. And I think that gets you to a level of transparency. Privacy is important, but aggregated, anonymized data should not put anybody in jeopardy. Mm-hmm. It should actually create a societal benefit. And I think, what I've heard a lot through the talks here, through the last 2 days, there's a real dichotomy, and I think there's a real discussion that needs to happen to really understand what we're scared of in sharing information. Is it, we're all worried about identity theft, for example. We're all worried about discrimination, declined coverage for pre-existing conditions. Mm-hmm. But can we get to a system where we can take those concerns and those fears off the table and really be able to use the data for good? So that's kind of just
Sure.
an example.
Well, I'll
Thank you.
Just building
Yeah.
off of what you're saying, Sumi, I think So one of the things just about Rock Health as an aside, so that you sort of know my context, we sort of do two things. We found our foundation is really in market and industry research, and we publish a ton of that. So you can go to our website and find out what we've worked on. One of the areas we've spent a lot of time around, for good reason, is AI and machine learning and data and healthcare. And one of the things we've done recently around that was to convene a group of digital health company CEOs, CTOs who are academically trained, PhDs in quantitative science. And we were fortunate, we invited Bakul Patel, who's from the US FDA, and he runs their digital health practice, and he joined us and observed. We did a day-long workshop. We essentially asked, what are the questions that, and the implications around data, and particularly as it relates to these new models in healthcare, whether it's privacy and many other things. The part that this group identified, and we came up with, there were 4 questions out of this working group. And you can go check it. If you Google FDA Rock Health Working Group, you'll probably find it. The one that relates to this was sort of one of the smart people in the room, not me, I was just note-taking, said, data is the active ingredient in the artificial intelligence and machine learning models that will power and are already powering a lot of healthcare. And so that insight has real implications. And if you take the analogy to drug development, for example, the molecule is the active ingredient, whether that's a small molecule or a larger molecule, biologic. That thing, that entity, is easy to observe in a scientific context in the human body. The data itself that was used to train a particular model typically is proprietary. So the company or the entity that used the data to generate a model that might have been FDA approved or might not be, and there's implications around regulation here. But just sticking with sort of the question about what's the obligation from an ethical point of view of an entity or a group of individuals who uses data to generate a model and those data may not be transparent, and they may not, the model therefore may not be easily replicable. And I think there's a bunch of questions around this that the panel, I would love to hear the panel kind of opine on.
Yeah.
Is it the active ingredient? Should it be proprietary? And if not, how do you make it both transparent while also giving those who developed it sort of the incentives they need and deserve to continue to work and do that hard work?
Yeah. Jay, I'd love to get your thoughts on that.
Yeah, no, I agree with what both of you said. I think there is a conversation that needs to be had around what do we feel comfortable sharing and when. And I think that we can advance to a higher point if we do that smartly and thoughtfully. That being said, I do think one of the benefits of living in a civilization that's excited about and interested in protecting privacy is that we can develop innovative solutions to solve some of those problems. As an example, Apple, as many of you probably know, is doing a lot of research on a pretty cutting edge area of computer science called differential privacy, where you can actually learn from the data on a device, but then introduce noise into that data as it's then aggregated at larger scales, such that the privacy of the individual participant is actually well held. So I think that's kind of one example of a very interesting use case. A second is actually exposing intelligence services or APIs as opposed to exposing the underlying data. So that's kind of a second major approach. The third is the one that Sumi mentioned about anonymized aggregated data. And machine intelligence and machine learning can actually be used to automatically de-identify, to essentially allow data to stay anonymized. So that's kind of a third one. And then the fourth one, which you also mentioned, has to do with having distributed machine instances which are running essentially algorithms locally, but then communicating their perspectives or votes up into a larger intelligence, almost in the same way that you're doing computation in your mind and you're sharing it with us, and then I'm doing some computation in my mind and sharing it with us.
Okay.
But we're not actually exposing the underlying data that exists in your mind, so to speak. So I think all of those are pretty interesting angles for us to begin having a conversation and solving some of these challenging problems.
Fascinating. Okay.
Just a follow-up on that.
Sure.
That's really interesting set of tactics. To what extent do you think there is an obligation for transparency versus, is that an imperative, or is it, or is there a sliding scale around it? Now, it's a leading question. Rock Health has been pretty forthright in our belief that we have to find economic models that support transparency.
Yeah.
We even engaged FDA in their rulemaking guidelines, most recent guidelines that have adopted transparency as one of the values. It was our proposal to put transparency into the rulemaking for the digital health pre-certification program. So that has to be balanced, of course, and the techniques for balancing it. But where do you guys?
Yeah,
see
I mean,
this?
I think as an open intelligence system, our goal is really to think about how we can enable technologies that can serve humankind and do so in a way that is transparent and audible and understandable, such that we can have more perspective on why systems are arriving at certain conclusions. And that's a major area of research in machine intelligence that you are probably aware of. So from a pure values perspective, 100% agree, but from a practicality perspective of what's possible in terms of making these solutions available and also having the private sector participate in such solutions, we need to think about these more hands-off ways of essentially having the participation of the private sector. Now, one interesting idea that segues to some of your blockchain work is you could very easily have a trustless system where people are inputting their data into almost the equivalent of a decentralized data marketplace, where ultimately the economic rights to the data could still be very easily tracked back to the participants with respect to who ultimately contributed that information to such a system, while still allowing that information to be non-commercial for other social uses.
I feel like that alone is an interesting segue. I'd love to get Josh's read on all this as well.
Yeah, it's fascinating. I'm reflecting on a pretty simple exercise someone asked me to do as a kid. They put a map in front of me and they asked me to draw a circle around all the people I cared about. And I remember how I felt holding that pen and drawing it. I couldn't imagine leaving people out of that circle as a little kid. And so I think maybe part of my role here is not to rain on a parade, but to flag the parade in a different direction, or at least the people who will come to certain communities and to certain problems, and a status quo that this year 5 million kids will die unnecessarily and unjustly. 4,000 kids today. And so I'm looking across the panel, I'm sort of wondering who will come with me and with those health workers on the front lines to solve that problem, because I am afraid to live in a world where that is normal, and most of the mothers and caregivers I meet are afraid and don't know what to do because their child is sick and the system is not working for them. Mm-hmm. So I think going right at those fears would be a worthwhile pursuit, and I couldn't agree more that data is playing a central role in how most health systems are shaping up. And if we take that as what's happening, then we consider that half of deaths don't have a cause of death matched to them. People are dying, we don't know why. And then you say, well, there's pockets where we have a ton of data about people we've never paid attention to before. My biggest concern, something that's I think both a technical and a design challenge for us, is how to avoid data science being the next extractive and colonialist industry in Africa and Asia. So I think that's our challenge.
Yeah, fascinating. Right on. I applaud that as well. And I don't see it as mutually exclusive by any means. I want to honor my promise to engage the audience right at the halfway mark here. There should be a microphone that'll rove. We already have one hand up. If we could run the mic up, that'd be awesome. And we'd love to really focus on questions. We are interested in your ideas as well, but there is a lot of expertise we want to draw on. So if you can really distill the question, that'd be great. So we'll go there, and then we'll go to this gentleman in the second row. Thank you.
Hi, my name is Melissa Estok. I'm with the Albright Group, and my question is two-sided, thinking about governments and then the people at the grassroots. And I was wondering how you deal, where your partnerships need to be with governments. What do you do in fragile states with undemocratic institutions or corrupt institutions? How do you find alternative ways, or do you just not go there? And then on the grassroots side of things, what about the garbage in, garbage out phenomenon? How do you check on the validity and the reliability of the information that goes into this.
Somebody want to jump in?
I'll answer the second half of your question. So this is a really complex problem in terms of how do you assess and understand the quality of clinical data. And the big problem is that, to the earlier point, systems aren't being deliberately designed to capture high quality information as well, right? So often we're analyzing data ex post that was captured for a completely different purpose. So electronic health records, as an example, are, at least in the US, primarily a billing and coding system as opposed to a clinical care system, and are very high signal to noise, unstructured. They really lack an understanding of a physician's thought process. They're really just outcome based. And to your biggest point, we don't know whether they're correct. We just know it's what that person said. So one of the ways that we're trying to solve that is actually creating a distributed anonymized validation process. So basically, as a case gets posted to our system, multiple physicians from around the world independently, without knowing each other, attempt to validate the answer or solve that case. Very similar to the way that the blockchain works with distributed machine agents attempting to solve a cryptographic puzzle. And in doing so, what we've been able to find is that the collective intelligence of multiple physicians, plus using machine intelligence across every aggregated case in the system, can outperform 97% of individual health workers or participants who are attempting to do such a case on reference training cases. And so then by scaling that information after you have reference training cases as a baseline, you can then look at de novo test cases and kind of say, hey, actually, this is probably very likely to be true with this extra layer of validation. And to make it cost effective, you can sample that such that you don't have to look at every single one. You can look at the ones that look anomalous based on AI.
I can answer the first.
Sure. Yeah, I'd love to hear a response to the first. And Sumi, I thought you might have some insights on that as well. But let's start with Shada real fast.
Okay, yeah.
Talking about the government, I consider myself an international patient. I've been born in the US, so I had my first record here. I was raised in Saudi Arabia. I had a second record there. I broke a finger in Egypt, so third one. I lived in the UK for 6 years, and then I'm back here in another state in the US. So I tried, and I've got, I'm asthmatic, I've got a thyroid condition, I've got skin contact allergy, so I've got to maintain medication that I like I said in my session, I cannot pronounce their name. So I looked at different systems, healthcare systems, and when it comes to government, it's very interesting that there are three players in the healthcare ecosystem. There are the regulators, there are the providers, and there are the payers. So in order to complete the whole story, you need those three players to work together. In some countries, the governments are three of them. This is when adopting technology will be mainly based on their interest in investing in that, and they have solo decision. They don't have to include any other members into that decision to decide. There are other governments where the government is only a regulator and the providers are different from the payers. And also in other countries, it's the regulator and provider, but not the payer. So it's very different, the ingredient, depending on how involved the government is. And the decision always goes back to the decision maker. So how much is the government involved in the decision-making process? This is when they get interested and involved in such things.
And Sumi, your thoughts on this?
Yeah, I guess briefly. So my background is actually mostly in infectious diseases and public health, and your question is actually spot on, especially when it comes to infectious diseases, which do not respect borders. But in all countries, health data is ultimately owned, in public health systems by the government. And this is a legacy issue that goes way back and trying to develop, so you can have an outbreak of something in Uganda, for example, and the bordering country DRC won't know about it because there isn't crosstalk of the information. We've actually done a pilot to look at, to get to your question about how do we improve the data. Unfortunately, I think that we have, in mobile health, people have gone from paper records straight to tablets or straight to lists on cell phones. And what we haven't done is we haven't taken into account, I mean, Medic Mobile has done this, and they've done this very well, but we haven't, in many cases, people haven't taken into account physicians' workflow and how we actually get the best data to be able to get information back. So just a quick story. So we developed at Vulcan as a proof of concept, we wanted to see if getting information back to clinicians would actually help and change their behavior. If it would be helpful for them to know, for example, that there was a malaria outbreak in the neighboring clinic. We're partnered with an organization that works in refugee camps in southwest Uganda, and they had a tablet that they're using for reporting data, and we said, well, why don't we just give you a system to analyze that data and send that data back to the clinicians. And we were able to actually, it's really simple, not rocket science at all. But just by getting that data back to the clinicians on a daily basis, they were able to change their behavior and treat patients much more efficiently. So we cut the time down, in many cases, from multiple weeks to just a day. What we hope that will come of that is actually, we've actually seen some of this already, the clinicians want to provide better data because they want better information back. So they want to provide symptoms. They want to know what this disease is presenting as in this specific instance. So it's, we're hoping to expand and really deal with the first part of your problem, which is how do we work with the Ministry of Health and other African countries to say, let's create an information ecosystem and a data ecosystem that will benefit everybody equally.
Great. Thank you,
Thanks.
Sumi. And thank you for those two great questions. Let's go to the second row here.
Francis Najafi, Phoenix, Arizona. I apologize for my potentially not so intelligent question, but I'd like to maybe go from global to local, I guess, U.S. By one account, our future net present value of future obligation of our healthcare is somewhere around $80 to $100 trillion. Knowing that our healthcare industry is obviously enterprise-driven, not driven by consumer, knowing that it's highly regulated, what are the low-hanging fruits from a digital disruption do you see that actually is going to somehow address our fundamental challenges in our current healthcare that goes beyond just data analytics or collection, the solution of privacy and data? Do you see other potential technology, digital solutions that are coming up in the coming 5 to 10 years? Not 20, not 30 years. Our crises are current right now. So what are the low-hanging fruits, solution do you see that actually going to somehow address this complicated challenge, knowing that it's highly regulated and we can't go around regulations?
Yeah, if I'll take the first
Sure,
one.
Bill, thanks.
I totally agree that, so we're in a crisis. That's totally clear. I don't agree that consumerization of healthcare, I do think that consumerization is a force right now, right? So for the first time very recently, consumer out-of-pocket spending eclipsed individually Medicaid or Medicare, not together as a composite. So we're on a trend for more out-of-pocket spending in the United States, and it's at numbers that are real for the economy. And then it's at numbers that are real for individuals, right? So I think for the first time last year, a third of, and I'm just going to use it as a data point, there are other data points to substantiate this claim, but employer-based health plans in the United States were high deductible health plans. And the average deductible for that plan is $4,000. Okay, so, and then if you combine with that, the median income in the United States is $59,000 as of, I think, November of last year when the Department of Labor last reported. We're talking real money for Americans. So I think that consumerization is now a thing. And I wouldn't have sat up here 3-4 years ago and made this claim, just to put that in sort of a context over time. So, but your real question was, where's the low-hanging fruit? I think it's linked to my belief in some sense that consumerization is real. And underlying that are a set of phenomena that are non-technical. I do think that the cost of diagnosis to zero is also a real phenomenon technologically. But that's not built on sophistication that's out of, futuristic. It's technology that's here now, it's capability that's being built collaboratively. And there are multiple ways to go about that. And so what that creates are new business models around fully integrating solutions, not within a hospital, but building a business from the ground up around a problem, right? And then creating technology within that business that is not the EMR of a hospital, but is really tuned to addressing patient need in a consumer-facing way, but with medical and clinical intelligence and the right kind of tooling. And so what that does is creates a completely different cost structure. And we've invested in a number of companies around this concept of a full stack. It's got all of the pieces in one company. You don't plug it into some other part of the healthcare system. Omada Health around diabetes prevention, Virta Health, which is still doing its clinical work, clinical studies around diabetes reversal, chronotherapeutics and late-stage FDA trials for smoking cessation and opioid addiction management, and I could go on to a bunch of others. So I think this model is out there and it's actually catching on. I wouldn't make the claim yet that we've seen tremendous success on the other side. We're a few years into that journey. So, but I'm incredibly optimistic about that as low-hanging fruit.
Thanks, Bill. I'd love to hear, Josh, your thoughts.
Yeah, thanks, Bill. I'm so happy the young one is with us because it's a trigger for me to think about love and what happens when the people that we love get sick and what we're willing to spend and what we're willing to do. And right now, our healthcare systems are putting 100 million people into poverty annually. And
Is this domestically?
globally.
Globally, okay.
Someone could probably
15
quote,
million annually.
Yeah.
probably quote the US number. We need to look at the system again. And I'm sorry, CVS is not community-based healthcare. And if I had a chance to sit down with a tool, again, I'll talk through what really different models of care look like, because I think the U.S. needs it. We need to rethink who's delivering care and where, and do so with focus on those who have been most marginalized.
Thank you. And I mean, what is your read of this new, tripart partnership between these three behemoth organizations?
I love what he was saying this morning. I love the abundance mentality, that resources won't be an issue, that medicine will be front and centered. I hope that the people around him let him do that and carry forward that mission. I also hope that the community, we figure out some way to learn as fast as possible alongside them. And I turn to Jay and the team. I wonder how we could set our systems up to learn faster from one another. Right now, we're relying on 5-year randomized controlled trials that tell us when implementation of an idea is or isn't working.
Yeah.
So I think there's a risk of that, taking too long to see what's working and what's not, and whether it's actually serving people and achieving outcomes equitably, I think is a big question.
Great. Thank you. Let's go to another question. We'll start second row right back here. Thank you. Just wait for the mic real fast. Thank you.
Hi, I'm Kara Weiss, CRI Foundation. We do healthcare in sub-Saharan Africa. So that's my perspective. And the current bone that I have to pick with what's going on in terms of the markets is that I think we're incentivizing an incredible amount of fragmentation. And it's causing chaos, it's causing redundancies of people's time and an incredible amount of money. And in the meanwhile, people are dying, information isn't being shared, and governments are left completely confused and without the resources that they need. So I bring it to the panel to tell me what we can do about this.
Sumi, I'd love to hear your thoughts on that. It's an easy one. Right?
Yeah, it's a huge problem, and especially in mobile health. So and I want to just pause really briefly. We've talked about digital health, and we've talked a lot about mobile health. We haven't really talked that much about the digital health, which is the digital health behind other medical devices, so around behind diagnostics, and that's another class that's incredibly important. So I just wanted to get that out there.
The knowledge.
So I'm talking about mobile health now.
You're talking about the knowledge that.
Well, yeah, there are so many medical platforms right now that are regulated by the FDA that have a digital component, and you can speak to this much more eloquently than I will, but that have a digital component, and so they're generating data. So the great thing about digital is it generates the data, and it makes the data easily accessible. It also is networkable, and it's also faster. But I'm totally getting off the track here.
Okay.
So sorry about that. So the fragmentation and the lack of ability to scale successful solutions and sustain solutions once they're scaled is enormous. I mean, it's probably one of the biggest challenges we face in global health, period. And it's not just mobile health, it's throughout global health. What are the solutions? I mean, what we're trying to do is and this is just infectious diseases, and we at Vulcan are trying to talk to all of our colleagues because we don't want to do anything either redundant. We absolutely don't want to keep reinventing wheels. So what we're trying to do is develop an API that will help all healthcare systems or governments process information, not via dashboard, because people on the front lines don't have time to look at a dashboard, right? I don't have time to look at a dashboard and analyze data. But how do we just get that key information back? We're going to have fragmentation in data ingestion systems until people realize the value, until we find those products, I think, that really come to market and are naturally scalable and sustainable. I think, Medic Mobile is developing some of those. Medic Mobile's done a great job. Demaji's done a great job. I think we're seeing that things are aligning more towards singular solutions. But I think we have to be patient too, and we have to keep talking together to figure out how we connect those systems that are working so that my, I don't know, this is a really bad analogy, but my WhatsApp account will talk to, another account on my phone, that's the best example I can come up with.
Okay, great. Thank you, Sumi. Question up here in the front row, and then we'll go back thereafter. Thank you.
My name is David Fuente. My question is this. On the stage, there's a tremendous amount of financial and intellectual investment in gathering data, using that data for treatments and so on. My question is, what portion of your investment is going toward prevention as opposed to treatment of disease? And is that ultimately a potentially more important solution?
Great question.
I'll start because you asked around investment. And I'll answer a couple different ways. First, our own portfolio is probably shaded more. We invest across a number of different things. Some of them are direct patient-facing. Others actually are payments-oriented and some other things. So we're pretty diverse. We have invested in a number of things that are preventive. So delivering better food and nutrition is a viable business model and something that can be scaled across economic strata now we're seeing, for example. So there are a couple of things around this. With that said, value capture on prevention in a capitalist society is really, really hard. I don't know how else to put it. And I don't think enough people are honest about this fact. And I think that the dishonesty, or if I shouldn't be so pejorative, but the failure to acknowledge that capitalism makes prevention hard you can't recoup cost on a preventive strategy in many respects. That makes it hard in our society. So we have to look to other mechanisms in some cases. Now, we work really hard to identify where we can strategies that do work and are economically viable. That's incredibly important because it's potentially breakthrough. So it's not as though we won't look, but we recognize that it's hard because how do you get paid for preventing a disease?
Yeah, just one minor point to add to that, which is that it's very clear that it's difficult to make a capitalist model work for getting paid to actually run a sustainable enterprise with respect to prevention, although hopefully there are ways to transition that. The more concerning thing is the same is true of the philanthropic world. The same is true because there's a short-term orientation towards easily measurable results as opposed to longer-term ambitious things which can potentially radically change the health and outcomes of large populations, but may be more challenging and speculative. However, interestingly, there is no financing mechanism for that, right? So for very ambitious, risky projects that are going to make a lot of money, there's clearly venture capital. For projects that have short-term, easily measurable returns, there's traditional philanthropy. Where we're really missing is that third bucket, and to your point, that's really where we need to go to really kind of change the cost of healthcare dramatically.
Josh, do you want to jump in on this one? I mean, I'll give you a moment. You're philanthropically backed, probably to a higher degree. I don't know how you count it exactly, Sumi, but than anyone on this stage.
I might just invite us to just really be really honest about what's going on. Like right now, it's extremely risky to be poor, risky to your health to be poor anywhere. And the difference in the income inequality in any country is outpacing differences between countries. So the gap between the rich and the poor in Malawi is the gap we're looking at now. Just to put another plug in and just to be a little controversial, we talk about non-communicable diseases, and it is the next wave. That should be redefined as corporate diseases, diseases that have been gifted to humanity by big companies. And my friends at General Mills are extremely friendly, but we should look at that honestly and have a discussion about it. And for us, we think that there are things that a health system can do, if designed differently, to make risk a non-static thing. So you can assess somebody's risk. You can assess the risk of someone getting type 2 diabetes or a child falling severely ill and dying unjustly. You can assess that risk. But the things that the system does, that a health worker wants to do, that a minister of finance wants to do, as a result of knowing that, as a global community, we need to step up and back that up. And it's going to take philanthropy, and it's going to take moral imagination. And I'm sorry, but I think that's the truth.
Okay.
If I can add a point.
Yeah, Shada, that's a point.
Okay. One of the very interesting things that the Saudi government is looking at, 91% of the population is actually young, meaning what they're looking for in order to help modernize the system, or have a better quality or achieve 2030 development of health and well-being, is by keeping people out of the hospital. Prevention. That's what we're talking about here. So they're doing it through the provision of three different systems, layers of layers of services that are pre-patient. The first is by educating and involving the individual, and they call it active people. They call them active people. It's not a patient anymore. Well, it's not a patient yet. By getting them the awareness that they need from home, school, and public about their physical, mental, and social well-being. This is the first layer, and they do it throughout their life using different systems. The second layer of service is by building a healthy community. If I go to school, I find healthy options. If I go to the university, I can find the gym, and there are room and hours where I can actually go and exercise. There are available gyms that don't close early. When I finish work, I can go to the gym. And in public places, we can find good, healthy options, and the society helps me be more active and live healthy and happier. That's the second layer. The third and final layer prior to a person becoming patient is by providing a virtual care layer, that when I see or I fear symptom or see an alarming symptom, I wouldn't go to and Google. No offense to Google, but everyone's becoming a Google doctor, and people go and search and try to find what's wrong with me. And you can find 10 symptoms that can apply to you, and you freak out. And then you go to a doctor, emergency room, and they tell you there's nothing wrong with you. So they're providing the virtual care layer, which allow me to go and talk to my doctor, get access to my information, and get to speak to someone. And now they have this unified number where moms and people can just call instead of having to go to the clinic just to make one decision. Do I really have to go to the hospital or not? And this engagement of person helps them be more proactive, more responsible for their for their health. So they take better care, make better decisions, and they are drivers of their healthcare outcomes. This is when prevention comes in, when they are aware and they don't make reckless decisions.
I find that fascinating. Is there anything else, any other countries that other folks are aware of that are doing something at that scale? Sounds fascinating.
Thank you.
Well, that's I think a pertinent response to the prevention question. Another question. There's two questions on this far side. We'll start with one in the back and then do the next one up front. Thank you.
Sure, thank you. I'm Hugo Diaz from Austin. I was talking to Shada about this earlier, but I want to throw it out to the whole panel and anyone in the audience because it's a complex issue that I've been thinking about. Is it realistic to leverage a technology like blockchain or another distributed system like the one you described, Jay, that would incent both payers, providers, and patients to keep their data up to date in a global system? And I think the challenge is not the technology, because we've heard the technology is there, but actually how to get everyone together and agree to do something like that. Does that make sense?
Jay, thoughts on that?
Yeah, so I think the reality is that the reason prior efforts like this failed, so a classic one is Google Health, is because ultimately those solutions provide nothing to the participants that are actually using them, right? So storing your data in a decentralized way or an anonymized way, that all sounds great, but it has to solve a very practical problem for the end user. So for example, if you want health systems to share data with you, you might need to do certain things. For example, improve their process of coding and billing by accessing your service. Or you may need to actually provide something to the end user, the physician, that reduces burnout. So for example, one of the ways that we're approaching that is taking existing regulatory requirements like peer review, maintenance of certification, continuing medical education, et cetera, and just automating that through your process of contributing through clinical documentation. So by easing that process, you can provide real value to those stakeholders. For payers, you can use that in a similar way around things like fraud detection and payments, or looking at how to assess claims from the standpoint of utilization management. Those are examples of places where you can provide real value to that stakeholder and actually get some outcomes for them that they want anyway. And so the key to your question is, could you actually bring that all together into more of a singular place and a singular system? I think the solution would need to be one that appropriately addresses needs for multiple stakeholders, such that they're all putting their related information into a system, but each have a strong value draw in their individual use cases.
Great. Thank you, Jay.
I'll enlarge on that.
Jump
if I
in,
could,
yeah.
just a little, because I think this is it's really central to a lot of the things we're trying to solve for. And it's relevant globally as well as domestically. So I'm actually curious about new paradigms, and I'm excited about things like what Apple has done to partner with, I think 24, maybe it's 27 hospitals now, and taking the approach of empowering individuals with their information. So it was the only stakeholder you didn't mention. And I think that that's a new look. And then Google Health and Microsoft, in fact, tried this 10 plus years ago without context. What I think has changed is the context around the individuals in healthcare for reasons I said earlier, but also the technology enablement has moved so much. It's hard to even imagine how much has changed in 10 years. So what I think will be interesting is to see when empowered and given utility for their data. Like I get something out of having my health data on my iPhone potentially soon based on that project. What then does that do to the other stakeholders? And so I have sort of a long pole in the tent theory that if you give one of the stakeholders enough power around and enough access to the data and the information, in this case I might argue individuals, the others kind of have to trail in or they get left out. And so we'll see if that unfolds. I think it's an interesting new paradigm.
Great. Thank you. There was another question up here, woman in the green, or the floral short. Yep. Midway up right here. Thank you. Mike is almost to you.
Oh, she's not floral from behind.
All right. Sorry about that.
I just want to echo the comment earlier about how do you get investors to invest in preventative. And, I think if you look at what what is actually happening with something like you mentioned Omada, for instance, right? The way that Omada is going to get paid, or somebody who's going to focus on a very vertical part of the health cost, is they're going to have some arrangement with some system, some health system that's going to say, okay, Omada, if you can save me X millions of dollars, we'll pay you for that, right? So they are, inherently investing in this preventative concept, right? Or at least chronic management in this case. But if you think about, a community, for instance, or a state, or whatever the entity is that says, I have costs, and if you can figure out how to take my costs off the table, VC investor, then yeah, I'll take your money. And an investor has every reason to get paid for the money that they save. And there are many examples. There was one earlier in an invest session where they didn't have to necessarily measure the end outcome 5 years later. They were just simply saying, okay, we'll vaccinate your population, and we don't know until 5 years later what that will look like, but we can tell immediately that X percentage of people got vaccinated, right? So that's our payout to you, investor. So I think, my point is I would really challenge people who are thinking that you can't invest as a sort of for-profit investor in preventative, because really that's probably the best sort of win-win strategy of a more community-based approach, where you get the state, government, community, citizens, and the philanthropist and investor all winning at the end of the day. And I think those are the models that, from what I've heard in the sessions, really are the game changers in how we really get at the cost that's going to happen in 2026 and 2034 around the unsustainability of health in America.
Great.
Yeah, you're
Thank
making
you so much.
me realize I probably need to. My wife's in the back with our baby. She'll tell you I'm a reductionist. I'm very literal. So when I took the word prevention before, I take it in the context of how do I get people to stop eating sugar, or how can I prevent them from ever doing things that ultimately cause an adverse outcome in their health. Rock Health was very lucky to be the first money in on Omada. So we're 100% behind what they're doing. I look at them as slowing or halting progression. And again, I'm probably splitting hairs here for this audience, perhaps. In the sense that you said then, I would say absolutely, there are plenty of ways to make money in the broader preventative paradigm that you're talking about. It's really, really hard, I think, in the upfront, changing behaviors before it leads to potential chronic conditions. So management and reversal and slowing progression are definitely viable. And if I spoke too narrowly before, I apologize.
Thank you, Bill. Josh, jump in.
I was just going to offer a question. We might ask flat out, if we want venture returns on health, or if we want venture returns on waste in health systems. I think that's a serious question.
And what's your response to that?
I'd rather redesign the system.
I'd rather do both. I think both are inherently tenable. There's so much cost to be taken out of the system by applying known technologies and known sort of process improvement that it would be a shame not to incentivize people to do that. And sort of one mechanism, and not necessarily the best, and I'd say this to companies that come to us all the time that are good businesses but not necessarily venture businesses, but one mechanism for that is a venture-based investment. There are a lot of other profit-motivated ways to drive that change. It would seem to me to be a shame not to use that lever when it exists and it's tenable and it's working.
Okay.
Can I make a related
Sure,
comment
Sumi.
to this? Sorry, just really short. I think, we've seen so Vulcan is sort of Paul's holding company, and one of the entities under that is the Paul G. Allen Family Foundation. In philanthropy, we're actually seeing a shift to looking through the lens of productization. So not just doing one-off projects to see an immediate impact, but saying, how do we develop for a scalable and sustainable solution from the beginning? And I think what that gets to, too, is starting to be able to integrate information across the spectrum and get to what some of those key determinants are for prevention as well. I think so. So I wanted to address the fact that profit and scalability isn't inherently evil. I think it's actually somewhat necessary to really understand the economic drivers, because it's not free. And we have to figure out how to make things more equitable at the end of the day.
Yeah, and just one minor point to build on that, to the earlier comments about the fragmentation of solutions, the same way that data monopolies have, to a large extent, hurt society in some ways with respect to large tech companies, the network effects associated with data or communities are actually what allow us to avoid this fragmentation. The only way we're going to get to solutions that can help all of society is if there are true network effects in these productized solutions that we're creating.
We have time for really just one more question. I'll go with the gentleman in the black shirt right here in the middle, right on the aisle. Thanks.
Sure. Hi, so building on a lot of what was just said, actually, I know there was some discussion earlier about that, for diabetes, finding a way to not have to engage with the system at all. And I think it's interesting in a consumerization type of market, as we're trending that way with high deductibles, finding the ways to get the lowest unit cost for the highest impact for that individual. But you do exist within a broader market, and a lot of the existing healthcare delivery system is fixed costs. And you can't, Amazon something and let Kmart go bankrupt in the same way in healthcare, the hospital systems and delivery. And I was just thinking, how do you kind of let that all play together and direct some of the digital tools towards improving the healthcare delivery system as it exists, as opposed to building, arms next to it that maybe could achieve, individual positive outcomes or cheaper outcomes?
That's an interesting question. Anyone want to jump in on that one?
So healthcare is a really capital-intensive business, which is just an economic way of saying you got to build buildings and buy equipment, given the way it's delivered today. And so for that reason, I'm not sanguine that the current system is tenable in all of the contexts in which we deploy it today, right? So there are ways that we're using the system today that I think once we digitize, we won't do anymore. And frankly, there are buildings that will have to be knocked down. I'm speculating a little here, but we've probably overbuilt. We've got too much capacity on the supply side, given where things are heading and the capabilities we're building digitally to meet that same demand at a much lower cost. And so I'm not so sanguine. I think there's actually some trouble ahead for our system.
One final quick word, Jay.
Yeah, just a final quick thought, just real quick. How many people in this room have done like a telemedicine visit? I mean, think about the fact that that's a very small fraction, given the fact that this is a group of highly educated, well-off people, right? And that is really the biggest place that this can happen. We need to create distributed, virtual, integrated care that exists outside of such settings, such that we can truly kind of reduce costs.
That's a big challenge. I just want to thank all of you for being a part of this discussion. Shada, you have enlightened me in multiple ways. I've been thinking a bit about the wisdom piece that you challenged. We didn't get to that. And Jay, thank you for your work. Josh, Sumi, and Bill, you all just added so much. Thank you to our audience as well. I feel like I learned a lot for sure, and I'm grateful for everything you shared. Thank you so much.
Thank you.